All right, we're recording now. Cool. Does everybody see our PowerPoint up on your screen?
Yes.
Yeah, okay. Anybody out there? Okay. Well, we're going to talk about the genitourinary system. And the genitourinary system, of course, the purpose of it is urination or elimination. And so we're going to break it down basically into two parts. This week, we're going to talk about the lower genitourinary system. Got to have my coffee in the morning. The lower genitourinary system will deal with the bladder and urination and bladder infections and bladder stones and that stuff. Next week, well, not next week because you're going to take off because it's going to be Thanksgiving. Yay. And then the week after that, we'll cover the upper genitourinary system where we'll talk about the kidneys. But let's dive in here. First thing we're going to talk about is the concept of elimination. There again, we were talking about concepts and how instead of studying the actual structure of the body, we want to study more what the body does or the concept of the body. And you'll find these will align better with your nursing diagnoses when you start doing your nursing care plans. We'll cover a little bit about the anatomy and physiology. I'll break it down into what each of the structures are. And this is all stuff you had in your anatomy physiology, so it should be old news. But then we'll talk about a couple of dysfunctions that can happen within the elimination system. Hint, if you see this guy, you might see it on an exam or something. Elimination. The concept of elimination is basically the secretion and excretion of body wastes. So what do we as nurses want to concern ourselves with when it comes to the concept of elimination? It's going to be to help establish that elimination system, especially if something has gone wrong with it, or if there is nothing wrong with it, to just help maintain it. Over the last week, you guys have been practicing inserting catheters and the like and that is one nursing intervention that we use to ensure that the patient can continue their elimination pattern. And there are others as well, and medications as well. So let's continue on and talk about the P. Here we go. There's basically two parts to the genitourinary system. There's the upper tract and there's the lower tract. Like I said, week 8, we're going to be talking about the lower tract, the bladder, the urethra. And I'm going to turn my pointer on here so I can write all over the screen and just annoy the heck out of you. Here we go. Let's take black. So it kind of, you start with the blood flowing through the kidneys right here. Oops, wrong one. There we go. Blood flowing through the kidneys, and then it goes down through the ureters. And you have 2 of them. You have one for each kidney. You have one on the left side. You have one on the right side. Actually, out of the patient's perspective, left side, right side. Got to get used to that. And then once it hits the bladder, then you have the bladder and the urethra. This is the upper. And this is what we're going to cover next week. The ureters, there's a debate. Okay, is the ureters part of the lower half or the upper half? I put it in the upper half, but it doesn't really matter. You'll hear this term a lot, KUB, kidneys, ureters, bladder. The doctor will say, well, I want an x-ray. I want a KUB. That's what he's talking about, kidneys, ureters, bladder. He's getting an x-ray of this area right here, probably for a kidney stone. So when you hear the term KUB thrown around, that's what it means. And we'll look at the blood supply going to the kidneys and what happens in the kidneys, but we'll do that on week 10. So what is it? Like I said, we're going to cover the upper part in week 10. But the lower part consists of the pelvic floor, and that's a sling which supports the bladder. If we go back up here a second, there is a sling along here, a tissue. I know my mother had a problem with a fallen bladder. You may have heard of that before, and that's where that sling doesn't hold that stuff up and it kind of drops. It's kind of like a hernia. But that is one part of the genitourinary system, the pelvic floor muscle. We're not going to talk a whole lot about any dysfunctions of that. There is the bladder itself, which is a hollow organ, as opposed to solid organs like the kidneys and the liver. This will contain it'll hold up to about 300 to 500 milliliters, 500 milliliters, half a liter. It can expand to a full liter, especially in the male. It's a little bit larger because the male doesn't have as much plumbing down there as the female does because of the reproductive organs in the female. So yeah, you can actually, the male can expand their bladder to a full liter at times, especially when you're on a very long road trip and there are absolutely no restrooms to be found. It gets pretty big. And then you have the urethra. That's the hollow tube that goes from the bladder out to the external meatus. In the female, it's rather short. As you saw when you were inserting the catheters, you only have to put about this much of the catheter into the female to get that balloon into the bladder. And because of the male penis, you have to go a lot further with the catheter to get into a male. They're usually about that long. I know guys like to say that long. That's not true. Assessment. We want to get the history of the individual. Whenever they have urinary problems, people that have, say, bladder infections have a tendency to repeat. They have a history of bladder infections. So getting a good history will kind of tip you off as to what may be going. Physical examination. There again, when we were talking about percussing, when you tap on the abdomen like that, solid organs have kind of a thunk sound to them, but hollow organs will sound like a drum. If somebody is retaining urine and their bladder is extended, you tap on this, it's going to sound like one of the drum sets from Journey. Diagnostic tests, radiography, x-rays, the KUB I was just telling you about. That's good for solid objects, like if they have a kidney stone. It doesn't do much for things like bladder infections. Ultrasound, there again for solid objects. CTs and MRIs if there is any kind of muscular problems like the fallen bladder that I was telling you about. These are where they actually invasive, where they actually go in and they can put a scope into your bladder. If there are polyps in the bladder, if there's cancer of the bladder, any reason we have to get in and look inside of the bladder. I think I got some slides on here that show the scope going into the bladder. If not, I believe at 10 o'clock when we talk about bladder irrigation, I'll be showing you some slides that shows what that looks like. But these are a couple of the tests. The most important assessment you're going to use on urinary or the elimination system, the genitourinary system, is the urinalysis. And fortunately, it's also the easiest. Here, go pee in this cup. But the urinalysis can tell you a variety of things going on with the bladder and the whole entire urinary system, from the kidneys on down, the entire GU system. And we're going to go into a lot more detail on this. I'm going to give you, there's even a chart in there, and I think I have put a urinalysis sheet online. If not, I'll make sure. If not, you can always print the one that I have in the slideshow here if you want to, but it's handy to have. Other labs are culture and sensitivity. You'll hear this term thrown around a lot. Culture and sensitivity. We can do it for urine. We can do it for blood. We can do it for wounds, for like bloody wounds or pus. Basically, a culture sensitivity Have you guys had that? Have we talked about the culture and sensitivity when we were talking about blood last quarter? Can't remember. Anyone? No. Okay. Basically, in a culture and sensitivity, we basically take whatever it is we're testing, urine, blood, wound discharge, and we put it in a petri dish and we grow it. And that allows the lab people to then test that whatever grows and see what kind of bacteria is infecting the individual. The sensitivity part of the test is where they put little samples of different antibiotics in the dish and see which ones work and which ones do not. Now, it takes several days for a culture and sensitivity. So if the doctor suspects you have a bladder infection and he gives you an antibiotic that he thinks will work, and then we do a culture and sensitivity on the urine, and 3 days later, if we look and see that the antibiotic that he gave you tested and it works against the bacteria, then we will do nothing. However, if we find out that the antibiotic that the doctor gave you is resistant to that bacteria, we call up the patient and we give them a new prescription for an antibiotic that does work. And sometimes you as a nurse will be involved in that process. A couple of days later, you get the culture and sensitivity back. It will tell you what antibiotic the patient got and whether or not it works. If it doesn't work, you may have the responsibility to call up the doctor, tell them that the antibiotic is resistant, get a new prescription. They will send it to the pharmacy. Then you call the patient and let the patient know that they have to go get a new prescription. But the reason they do that is they don't want the patient to wait for 3 days to see what antibiotic will work. We want to get them on an antibiotic right away. And very rarely do we find out that they are resistant to that antibiotic, but every once in a while you do. Moving on.
Dan, I have a question, Bill.
Sure, go ahead.
Bryce, sorry. So the nurses are responsible to call the doctor with the labs, or do the doctor already has the labs and then calls us to tell us what medication to give?
It all depends. It all depends. I have worked places where we got the lab results back and it was our responsibility to call the doctor's office.
Okay.
Other places may work differently. So it all depends on where you work. But I remember, especially with the charge nurse, that was one of the things that she would check is she would go through the culture and sensitivity results and find out if anybody needed to get their antibiotic changed. Okay. It depends where you work.
All right.
In a hospital, you probably won't do that. I worked in an outpatient clinic where we had to do that. 24-hour urine collection. This is where they give you this huge bag and they send you home with it and you collect your urine over a 24-hour period. And this is usually testing for protein, which can be symptomatic of kidney failure. A urine specific gravity, urine osmolality, those usually are a part of the urinalysis. So I don't know why I've got it separately down here. And in fact, both of these right here, the BUN, creatinine, oh no, I'm sorry, these are blood tests. Well, the specific gravity is a part of the urinalysis. It's actually, it's testing the osmolality, you know, how concentrated the urine is what that is. But the BUN and the creatinine, these are blood tests. Those are in that list of blood tests. In fact, those are part of the CMP that I told you about in lab. You remember they were part of the fish diagram? And those tell us about renal function. When your BUN and creatinine start going up, you are probably going into kidney failure. So, but we'll talk more about that 2 weeks from now. Now, remember, the most important analysis for the genitourinary system is a urinalysis. That's where we start. We move forward from there. I like the way he flips around there. Okay. Here is a copy of urinalysis lab results. And these are the things that we look at. What the color of the urine, because the color will tell you several things. How clear, if it's pink, there's blood in it. If it's green, you got an infection. You start seeing green urine, boy, I'd go straight to the hospital. The clarity, it should be clear. Your urine should be a very light yellow and clear. If it's anything but, this is a good chart to look at to see what may be going on with that. And we're going to hit on these as we go through. Now, here again is the specific gravity and the osmolality. This shows basically if your specific gravity goes up, it's because you got a lot of extra crap in your urine that shouldn't be there, like protein, pus, glucose, etc. Your pH of it, ketones, that's very important for diabetics. Eileen will talk more about that with diabetes. Proteinuria, that happens in some of the things we'll be talking about that in the future as well. Glucose, there again, that's diabetes, which is Eileen's baby. She loves talking about diabetes. Bilirubin, if you're having liver problems. I'm sure we've talked about liver failure or hepatitis. You turn yellow. Well, you see a lot of that crap in your urine as well. Your urine gets kind of ugly when you have hepatitis or liver failure. Crystals, we talked about gout. Crystals can show up in your urine if you have gout. There's other type of crystals. When we have a kidney stone, things like that. We'll talk about that as we go along. And of course, bacteria. If you're positive for bacteria, then you might want to take this urine and send it in for a culture and sensitivity. Now, you need doctor's orders for all these, of course. What is the stricture? Okay, now we're going to get into the three dysfunctions of the genitourinary system, and I'll be hitting on the urinalysis as we go through so you can correlate the two together. A urinary stricture basically is just a blockage. Anything that blocks your urination is a stricture. It can be the tube itself. Now we're talking either the urethra or the ureter contracting to stop your elimination. I'm not going to talk too much about a calculus because that is a kidney stone. I'm going to talk about that separately. Other things, though, can be congenital defects or scarring. The scarring can be caused by repeated kidney stones or an infection. You know, when you have something infection, what does it do? It swells up. Well, your ureters, your urethra can do the same thing. They can swell up, causing a blockage. Now, what this does is this causes urinary retention. If you have a blockage too long, the bladder, it can cause the bladder to try to create a different opening, which is a diverticulum. In other words, it's causing a hole somewhere else, which can lead to a multitude of problems. There's a lot of parts of your body, like for example, the Bartholin cyst. Females have Bartholin cysts in their vaginal area. And we can actually take a needle, poke it into the bladder or into that cyst, and it will create a separate duct on its own. Your body is really good at trying to adapt to situations. Sometimes we don't want it to do that because it may create an opening going somewhere we don't want it to go. So that's an adaptive capability that sometimes can go terribly wrong. And there's a lot of organs in the body that can do that. We'll talk about the ureters in week 10, but in the lower part of your GU, in the urethra, usually a stricture is caused by, in the male, the prostate enlarging. There is a prostate organ in the male that produces juices that are released during sexual activity. And I'm sure all of you have heard of prostate cancer. There is also another disease which is not cancer called benign prostate hyperplasia, BPH, which we will talk about also. And both of these cause that prostate organ to swell. Well, that organ is right next to the male urethra, so it blocks it off. And gentlemen with the swollen prostates have a tendency, it's very difficult for them to go to the bathroom. So that is an example of a stricture. Another one is a sexually transmitted disease. It causes swelling in the urethra, which again prevents you from urinating. So the assessment is actually pretty simple in these. It's usually going to be a verbal. How is your urination? How much are you putting out? Do you have burning on urination? Urgency is that feeling that you have to go to the bathroom, but you can't. Hesitation is when you're, standing in front of the toilet and you just can't get yourself to go. And hematuria, that's usually more evident in things like when you have scarring or infection, which is hematuria is blood in the urine. So any of these, when you're talking to the patient, you want to ask them about these things. If the person does give you a urine sample, you might see something in the urine, like it'll be pink if there's blood in the urine. So, but most of this is going to be verbal unless you want to, kind of tap on their bladder to see how hard their bladder is. Diagnostics in a UA, in a urinalysis. I'm sure I mentioned it, but UA is our shorthand for urinalysis, the test I was telling you about earlier. You'll want to look for blood if there is scarring or WBCs if there's an infection. If they have a bacterial infection, you'll get white blood cells in their urine. You will also get some blood. With the inflammation of an infection, you'll get some blood leakage in the urine as well. So if somebody has a UTI, they may have some blood in the urine as well. Kidney stones is usually what causes a lot of blood. And this might require a uroloscopy, and that's where they put the little scope up into your urethra to check out and see what's going on. And there's the picture I was telling you about. Here's an example of how that works. This goes into the bladder, and this is just used to see what's going on. This is the light source. This is an irrigant. Especially if they're looking in the bladder, they have to wash the bladder out real good to see what's going on inside the bladder.
Hey, Bryce, I have a quick question.
Sure.
So I know this is going to sound kind of stupid, but you said hesitation is when you're standing in front of the toilet and like can't go. If for women, is that like when you're sitting on it and you can't go, or like is that like hesitation to even get yourself to go to the bathroom?
Hesitation is the same for males and females. It's just I want to go, but I can't get it to go.
Okay.
You have to sit there for a while. It's very, very common in males with the swollen prostate. You're standing in front of the toilet going, oh, come on. And that's because the urine is trying to get out, but the urethra is kind of swollen shut. So it takes a long time for the urine to force its way out. Does that make sense?
Yes, that makes sense. Thank you.
Okay. Now, that's as opposed to something else, or is that clear? Okay, well, thanks, God.
Yes, sorry.
Now, some people have
multitasking.
hesitation. This is not the same kind of hesitation you have, like, I'm in public and I'm embarrassed and I don't want to, go to the bathroom in a public place or something. This is where you're really, really trying to go, but you just can't get the urine to come out. I guess the other one would be psychological hesitation, but that's not what we're talking about. How do we manage this? Dilation, do I have a picture? Yeah, I do. This is all stuff that's going to be handled by the urologist. If you have any of these problems, they're going to call in a doctor. It's going to be a urologist. And if you have swelling in the ureter, they can use, it's called bougies. Bougies, yeah. I think I'm pronouncing it properly. I know everybody knows, hey, she's so bougie. I think it's pronounced exactly the same way, actually. But the bougie is basically a very stiff rod is what it is. And the urologist will put this up the ureter to dilate it and get it to open up so that the individual can urinate. Now, you will also see if you have a case in the an emergency room or even in a med surg unit where the individual, you can't get the catheter in. And we've run into this in many cases where we just can't get the catheter to pass through into the bladder. You actually have to call a urologist in, and I don't think ER doctors will do this, it's strictly urologists. And they will take these bougies and they will use these to dilate the ureter. And some of them are metal, and they're really quite scary when you look at them, to be honest with you. But this can only be done by a urologist. They're the only ones that are trusted to do this, because as you can imagine, so much can go wrong on this. You may have to assist the urologist while they do this, but we don't deal with the bougies. That's all done by the urologist. And urethroplasty, that's where they actually stick, oh, I guess I don't have a picture of that. That's where they actually go in surgically and dilate, and they may even have to cut out tissue to enlarge that. Now, we'll get a good example of that when we talk about BPH, because when your prostate actually surrounds your urethra or your ureter. So when that swells up, it actually clamps it closed, and they may have to go in with a process called a TURP, which we'll talk about at 10 o'clock. They're actually cutting tissue out of the prostate to open that hole up again. It's quite an involved procedure, and I'm sure you will see some in the future. So we're going to talk a lot about that. What do we do as nurses? Analgesics, definitely. A lot of medication. We're responsible for giving them the painkillers to help with everything that's going on, and the antibiotics. There is a drug called pyridium. It is also sold on the market. It came several years back, it became over the counter. And pyridium is to help decrease the pain that you experience during a urinary tract infection. There was a heated debate about whether they should release that to the market or not, because if you have a bacterial infection of your bladder and you take this pyridium and the pain goes away, you're not going to go to the doctor and get the antibiotic you need to fix the problem. You're fixing the symptom, but you're not fixing the problem. So that's something you have to emphasize with people, and not just your patients, but anybody else you run into on the street. If they're having trouble, if they're having pain on urination and they're taking pyridium and the pain is going away, they're not fixing the problem. They may have to go in and get antibiotics because they may have a bacterial infection. So that's just a cautionary note about the pyridium. And like I said, on the commercial market, it's called Azo when you go to the drugstore and get it. What kind of medication is going to be, of course, determined by what the cause is. There's no need giving antibiotics to somebody with a swollen prostate. That's not going to do anything. And post-surgical management. If the individual has gone in for uroscopy, or if they've had a TURP or anything, you will have to manage them post-surgically, and we'll talk more about that when we get into those particular dysfunctions. What is calculus? System of mathematics developed by Sir Isaac Newton while on quarantine during the plague. Hey, that's not the calculus we're talking about, but I thought it was funny. A calculus is a single precipitate of mineral salts. It's a stone. We call them stones. If you have several, they're called calculi. Thank God for Latin, right? A precipitate of mineral salts. This is a kidney stone. This is what we know as a kidney stone, but it can also be a bladder stone. It can also be a stone blocking your urethra. It can be anywhere in the lower or the upper genitourinary system. There you go. Calculus is singular, calculi is plural. This has a tendency to be ongoing. People who get kidney stones have a tendency to get kidney stones again. And over the ages, there have been a lot of myths about, okay, what causes kidney stones and all that kind of stuff, and don't drink milk, stuff like that. We used to collect the stones when, if the individual had these, and they would analyze it. They would send it to a lab. And if it was a calcium salt, we would tell them to stop drinking milk. If it was a magnesium salt, then it doesn't matter. But actually the only thing that they've really found in general that is a cause of kidney stones is dehydration. You have to stay hydrated. If you dehydrate, the salts will collect and form stones. So we're kind of talking, I'm going to cover both the upper and lower genitourinary here because stones can form in the bladder. They have to be much bigger though. Your ureters are tiny. They're very, very tiny tubes that go from the kidneys to the bladder. Therefore, usually if a stone works its way through the ureter and into the bladder, going from the bladder out the urethra is not a problem because your bladder is big and your urethra is a bigger tube than the ureters. So usually if you have a calculus that goes through your ureters, once it gets to your bladder, you're off the hook. But every once in a while you may get a bladder stone, which is much bigger, and that can block your urethra. And then you have a real problem. I'm kind of doubling over here on the upper and lower, but if you get a kidney stone and it gets in the ureter, you're going to get severe flank pain, right? Your lower back area back here, back where somebody gives you a good kidney punch. And it comes in waves. And the reason you're getting that pain in waves is because like your gastrointestinal, your intestines, they use peristalsis to move stuff. They go like this, they move in waves to move stuff through the intestine. Well, your ureters do the same thing. Your ureters use peristalsis to move stuff through them. And it's usually not as bad because it's usually just liquids, just water, right? Well, you get a stone in there and that peristalsis moves over the stone. It's extremely severe pain. And that is why it comes in waves. When you have the peristalsis, you feel the pain, and then the peristalsis stops and lets up and you're okay. So those who have kidney stones, you're going to get these big waves of pain, and you're going to feel it in your left lower back or your right lower back, depending on which ureter it's going down. And has anybody out there ever had a kidney stone? Nope. Working in the ER, kidney stones are the only thing that women have told me is worse than childbirth. These are extremely severe. Kidney stones are horrible. If you ever talk to somebody who's had them, and they're pretty common. I mean, we all probably know at least one or two people who's had kidney stones. They're a real pain. You're going to be giving them a lot of analgesics, a lot. Moving on. Yeah, what I thought was really interesting, I didn't know this before I researched this, the smaller stones are more painful than the big stones because the smaller stones are moving through the ureter faster. So they cause more pain. I mean, who'd have thunk, Prolonged blockage can result in infection. Now, this is important for basically all of our urinary, or all of our genitourinary discussions. Anytime you block off that urine and that urine gets stuck somewhere, well, you know how when you pool blood and blood gets stuck, it'll coagulate. Well, anytime urine gets stuck, it can grow bacteria. So anytime you have any case where you're blocking the urine and the urine's not flowing, you're increasing the risk of a bacterial infection. We got to keep that stuff flowing. It's like whenever you get a kidney stone, the doctor's going to say, keep drinking, keep drinking, keep drinking. Flush that system out. If we stop the urine from flowing, we risk that calculi or that calculus could create a urinary tract infection. Here's a picture of one. And I guess they even have names for the parts. Now this looks big, but this is really a very tiny, tiny thing. You can see on the bottom there, this is a big one. But normally they're smaller than a grain of sand, or a tiny grain of sand. And it always amazes people because if they do, we give them a basket, and if they catch it, and they look at it, and they're amazed because how can such a tiny thing cause so much pain? Okay, how do we know? Urinary analysis. The urinalysis will usually show blood because as that ugly thing to the right of the screen there is crawling down your ureter, it will tear the inside and cause bleeding. So you will get blood in your urine. It's like 99% of the time you'll have blood in your urine if you have a kidney stone. WBCs, not so much unless you already have an infection starting. May require uroscopy. And I guess they can go all the way up into the ureters with these things. I've never seen that, but I've heard they can. How are we going to manage it? Okay, two important things you want to do with somebody who has any kind of calculi is you want to encourage them to drink fluid, flush that thing out. The more fluid in there behind the stone, the better chance you have of flushing it through. 99% of the case of kidney stones, we don't do anything but give them pain medicine, which is the analgesics, and wait for it to pass. And that is not a lot of fun. The larger stones, however, if you have a big stone like the size of a BB or say a marble or something, those aren't going to pass through the ureter. The ureter is too small. So they may have to do a surgical intervention. The more common one is lithotripsy. ESWL is another abbreviation for it. But that's the one you probably heard about, where we put the patient in a very large jacuzzi full of water, and we use sonic waves to break the stones up. Hopefully we break the stones up into smaller ones, which can then pass through the ureters and into the bladder and out through the urethra. Any questions on that? You might want to remember that because you got the funny little guy with the pipe over there. Sometimes we can put a stent. This is just like, I know when you were doing cardiac in Med-Surg 1, we were talked about heart attacks and going into the heart lab and enlarging or clearing out a blood vessel and putting a stent in. Stents, try to get this open here. I don't think I can. Anyway, I had a pen here. If you take a pen and you open it up and you got that little spring, that's what a stent looks like. It looks like that little spring that you get out of a pen. I'm gonna have to get one of those and stick it in my desk. But that's what a stent looks like. Oh, it's a lot smaller than what comes in your pen. We can do that in your ureters as well. So we could actually feed a line up into the ureter. We use a balloon to open it up and then put a stent in there to keep it open. That's very rare. I haven't seen a whole lot of those. But if we have some, that may become necessary if you get a lot of scarring. Every time these stones go through the ureter, they're going to cause scarring. And like I said, I've known people that have had repeated kidney stones and they get a lot of scarring. If you get enough scarring in there, that we actually have to have a surgical intervention where you go in and actually open it up. What are we going to do as nurses? Analgesics for the pain, antibiotics. I don't know if we give it to them prophylactically. I don't think so. I've never seen that. But, you know, the doctor, if somebody has a prolonged blockage of some type, the doctor may want to give them an antibiotic. And we usually don't give antibiotics prophylactically to make sure they don't get an infection. We usually wait until they get an infection. But, you may have to administer the antibiotics for them. And I'm sure you probably remember a lot of the stuff about antibiotics, what we tell patients. You know, it kills off the good bacteria too. So take I can't remember what the name of them are, but take those pills like yogurt, but oh man, they just went right out of my head. Those pills that put the good bacteria back in your intestines. Encourage fluid intake. Repositioning, sometimes that helps with the pain. Moving on your side. Use of a filter hat. Sometimes we have these little hats, they look like a witch's hat, and they have a screen in there, and we want the patient to pee through the screen to catch the calculi, if the doctor wants to analyze the calculi. We used to do that a lot. I'm not seeing it as much anymore, but you know, your doctor may want them to do that. Post-surgical management if they have a surgical intervention. Now, cystitis, we'll move on to any questions on the calculi before I get into cystitis. Now, I kind of stepped over into the upper genitourinary tract with that, but I wanted to cover the blockages all in one group. Nope, everybody still awake out there? Everybody got their cup of coffee? Good. Okay, we got the little Sherlock Holmes here, so something's coming up that we may need to remember. What is it? Bladder infection, that's what it is. Cystitis, cyst is commonly used in the genitourinary tract terminology. I really don't know what the Latin for that, what it means. But itis, of course, always means infection, right? Yeah, itis means infection. A lot of people call cystitis a bladder infection. That's what you'll hear people on the street calling it. I got a bladder infection. Usually it's just a bacterial infection of the bladder or of the ureter. Yeah, you can get a bacterial infection up in the ureters as well. Anywhere along the entire tract can get infected. If it gets up to the kidney, that's called pyelonephritis. That's a different terminology for that. But it's usually a bacterial infection, very common in women. The reason it's common in women is the ureter is shorter, so it's easier for stuff to get into the bladder, especially during sexual activity. So that's why women have a tendency to get bladder infections more than men. It can be a mechanical problem. There again, anytime you're blocking the flow of urine, you increase the chance of a bacterial infection. So if the man's prostate is swollen, he's not peeing as well, he can get an infection. Pregnancy, things aren't flowing as well, can get an infection. Sexual intercourse, there again, because the women's urethra is shorter, it's easier for bacterial infections to get in. Mechanical scopes and catheters. Now there again, we're talking about a urinary catheter. That's why we have to practice sterile technique when we put that catheter in, because we are increasing the chances for a bacterial infection every time we put a catheter in, or if we fail to maintain its cleanliness while they have it. Whee! Another somersault. Okay, how do we assess this? Normally, anytime you have problems in the urinary tract, it's usually going to manifest as lower back pain. That's just a good clue that something is going on there. And it will usually be on whichever side. If it's not, I'm sorry, you have a question? Sure.
I'm sorry to take you back to that other slide.
Pardon?
Can you go back to the other slide?
Okay.
Sorry. I just wanted clarification between cystitis and UTI. Are they the same thing?
Cystitis and UTI?
Uh-huh.
Yes.
Okay.
On the street, they call it a bladder infection. In the hospital, we call it cystitis.
Okay. Thank you.
You're welcome. Lower back pain. When you have a bacterial infection, you have swelling, which is going to cause difficulty urinating, dysuria. You may get blood in your urine. And the biggest clue, when somebody has a bladder infection, and you've probably seen this, or anybody who's ever had a bladder infection, your urine comes out cloudy and foul smelling. I mean, that's the big clue there. Anybody who has common bladder infections will look at their urine and go, oh, okay, I got another bladder infection. The only cure for that is antibiotics. I mean, you can drink all of the cranberry juice you want. It's not going to fix the problem. If you get cystitis, you need antibiotics. Oh yeah, and it's an infection. So you have everything that goes with the infection: fever, chills, maybe some nausea, everything that goes along with those wonderful bacterial infections. you don't want it to go systemic. You don't want it to go system-wide. So if you get a bladder infection, you get into a doctor and get it taken care of. Diagnostics. There again, what's the best diagnostic tool we got? UA, urinary analysis. If it is an infection, your body's launching an immune response. You will have white blood cells in your urine. You may have blood, you may not. It's very common to have blood though, because that infection causes the leakage of the blood into the urine. You may have to do a CNS, find out what kind of bacterial infection you have and make sure the antibiotic you're on is effective. Okay, I guess that's it for that slide. Medically management, how is a doctor going to manage it? Antibiotics, Cipro, levofloxacin are very common antibiotics for bladder infections. If any of you out there have had bladder infections before, you've probably gotten those. There's also the Z-Pak, the Z-Pak where you just like take it for 5 days and it goes away. I've seen those prescribed. There again, here's pyridium, which I was talking about. Here's the full name for it. Phenazopyridine is the generic name for pyridium. In the hospital, we call it pyridium. On the shelf in the drugstore, it's called azo. Now, one thing to tell people about this pyridium, if you prescribe that to a patient, they're going to go home, it's going to turn their urine bright orange. Tell them not to panic. That's the drug that does that. It doesn't mean there's blood in their urine. It doesn't mean they were abducted by aliens in the middle of the night. It's perfectly natural for pyridium to turn their urine bright orange. And I mean, it's really bright orange. It's noticeable. It's not subtle. Cranberry juice, there is some evidence that cranberry juice is beneficial in bladder infections. Evidently, they discovered that it helps keep the bacteria from adhering to the bladder wall. So this is one of those old wives' tales that may actually be true. Cranberry juice is good to use. And I think it's probably a pretty good preventative for people who get frequent bladder infections to kind of help keep them from getting further infections. I think that is it on the cystitis. If there's any questions, nursing management, still got one more. There again, we're going to be responsible for issuing analgesics. And I guess you could call the pyridium an analgesics because it helps in relieving the pain. But they may also get some kind of opioid to help with the discomfort while they're going through the process. Antibiotics, you want to fill them in antibiotics. Or encourage fluid intake. The more fluid we flush through the system, the better chance they have of healing and clearing out that bacteria. Cranberry juice is a real good idea. Any more questions on any of this?
Bryce, I have a quick question.
Sure.
Why is cranberry juice such a good idea? Like, why? What is the like rationale behind that?
It keeps the bacteria. They have evidence. Usually, what they say there's some evidence means it's not not been proven totally, but they've done some labs and they've found that it helps keep the bacteria from adhering to your bladder wall.
Gotcha. Thank you. I missed that part of it. Thank you.
No problem. Anything else, anyone? I'm going to stop the recording at this point.